My name is Jade Davies, and today I will be reflecting on experiential learning and clinical debriefing. Today, I will be incorporating a job that I went to in my final paramedic placement into this video, and I will be using Gibbs' reflective cycle to formulate this presentation to highlight the importance and relevance of experiential learning and clinical debriefing in paramedic practice. Experiential learning is the process of learning through experience. Debriefing is a retrospective analysis of an event and a guided reflection for experiential learning. Debriefing is grounded in experiential learning theories. As such, it is intrinsically associated with the concept of reflection and differs from feedback or assessment in that it requires a two-way communication process between the educator and the student to help the student understand the situation and develop strategies to improve in the future. Clinical debriefing occurs often through a paramedic's day-to-day work life. It may be after a low acuity job where a lift assist did not go as smoothly or as planned, or after a more critical patient where a CCP attended. Debriefing may also occur after a simulation. Research has shown that it is vital to incorporate clinical debriefing into a healthcare professional's line of work, as it has positive effects on confidence and improved satisfaction. It is also important to debrief after an event that may have triggered an emotional response within the paramedic. Debriefing, as mentioned before, requires a two-way communication and allows for feelings to be addressed. Research has shown that by debriefing after an event, it can decrease the level of stress, the rate of burnout, and improve the ability to provide adequate patient care. This is particularly relevant to paramedic practice and for future paramedics to be aware of, as any paramedic has the chance of dealing with an event that may be emotionally unsettling and triggering. Kolb's experiential learning theory defines learning as the process whereby knowledge is created through the transformation of experience. Knowledge results from the combination of grasping and transforming experience. Kolb also created the learning cycle, which consists of 4 phases. The concrete experience. This is the phase where the learner takes part in an experience such as simulation, lab session, or fieldwork. The second stage is the reflective observation. This is where the learner reflects on their own personal experience. Abstract conceptualization is the third stage, where the learner considers what they have learned from the reflection and identifies areas where they may have done something differently to positively enhance the outcome in the future. And lastly, the active experimentation phase. This is the phase which involves using what was learned to direct future practice. In addition to the learning cycle, Kolb also recognizes individual learning styles and the importance of these. The 4 learning styles that Kolb recognizes are as follows. The diverging learner, who learns best through concrete experience and reflection. Assimilating learner. This type of learner prefers a concise and logical approach. These types of learners work best through reflective observation and abstract conceptualization. The converging learner. This individual learns best through abstract conceptualization and active experimentation. These types of learners prefer technical tasks and can use their own knowledge and learning to problem solve. And lastly, the accommodating learner. An accommodating learner works best with a more hands-on approach. These learners use other people's information to formulate their own analysis and prefer a practical and experiential approach. Now I will present to you a case study which will highlight the significance and importance of clinical debriefing and its relevance to paramedic practice to enhance learning. My crew and I will call Code 1 to a 3-year-old child who was unresponsive. On our arrival, the child was lying on the bed, grey in colour, unconscious but still breathing. The mother told us that he had a congenital disorder and was palliative. He was not for resuscitation or intubation. We immediately called for CCP backup while getting all the vital signs. The patient was tachycardic, tachypneic, and had low SpO2. We immediately started ventilating the patient and controlling his airway. Prior to this, I had only ventilated adult patients, and in the situation, I very quickly became overwhelmed and stressed that this was a pediatric. The CCP arrived and asked me to switch with my mentor and provide IPPV. He asked me what the tidal volume of a 3-year-old was. I had no idea. I immediately felt embarrassed and disappointed, as if I should have known this number off the top of my head. I continued to control the airway the whole way to hospital. The CCP cannulated the child, but no drugs were given. The mother told us that he had been his usual self throughout the night, when he vomited and then instantly became unresponsive. His SpO2 on their home monitor read that he was at 73%. It was assumed that the child had aspirated. Once we got to the hospital, the ED staff continued to ventilate for the patient. The child later in the evening was transitioned into palliative care, where he passed away. This encounter represents the concrete experience in Kolb's theory. After the job was done and we had handed over to the hospital, we had a debrief session which was run by the CCP. This is where the next two phases of Kolb's theory is applied, the reflective observation and the abstract conceptualization phases. As previously mentioned before, it is important that clinical debriefing sessions are commenced after an event that may be emotionally triggering or unsettling to the paramedic. Clinical debriefing allows for these feelings to be addressed. I felt very overwhelmed when I was given the opportunity to ventilate a child. As I mentioned before, this is something I had never done before. I also felt embarrassed when I could not tell the CCP what the tidal volume of a 3-year-old was. There were certain things that I had forgotten in the moment, especially how the anatomy of a 3-year-old differs to the anatomy of an older patient, and therefore the way you ventilate and provide a good seal around the BVM is completely different. It was also hard to see the family so distressed throughout the job. The mother and the grandmother were both present and they were both crying hysterically. In a lot of cases, it would be appropriate to ask the family if they would be more comfortable stepping out and not watching. However, we all knew that this was probably the last time the family would have their son in their house with them. This was emotionally unsettling for me. Initially, I was ventilating the child incorrectly. However, I quickly realized and changed my hand position for the chin lift. The child's SpO2 quickly came back up, and after I had done this, he became more responsive. It was a good learning experience to be able to ventilate a 3-year-old child, as even the CCP said that not many people have had the chance to control a 3-year-old's airway. Once the job was complete, my mentors, the CCP, and myself had a debrief session. According to Rose and Chang, 2018, post-event debriefing allows the healthcare professionals to reflect and learn from their performances. In terms of my case study, it is evident that there is a huge difference in size and lung maturity in pediatric patients. The larynx is relatively higher in the neck of children, and in some positions the mandible may lie in line with the upper glottis structures. In this case, I positioned my hands incorrectly on the mandible, meaning that my ventilation was ineffective. However, partaking in the clinical debrief session allowed me to learn from this experience. I practiced my ventilation skills when I got back to the station to ensure that I had the correct technique. This case study highlights the importance of clinical debriefing. It is essential that paramedics partake in clinical debrief sessions where necessary to ensure constant skill and knowledge enhancement. This will further ensure that paramedics learn from their experiences and are able to provide adequate patient care. Clinical debriefing and experiential learning are two concepts and practices that go hand in hand. As discussed, debriefing after a clinical event, whether it be a real job, a simulation, or lab session, provides opportunities to define and discuss gaps in medical knowledge, clinical performance, and behaviours that directly relate to patient care. By reflecting on the clinical encounter or concrete experience, individuals are able to identify strengths and weaknesses, areas for performance improvement, and enhance interpersonal skills and communication. Experiential learning and clinical debriefing are core elements of paramedic professional development. Clinical debriefing should be applied when emotionally triggering events occur. This ensures that the emotions the paramedic is feeling is addressed, and whether further investigation of these feelings need to be focused on. Debriefing should not be limited to emotionally unsettling events or poor outcomes. It is also important that the paramedic debriefs when there have been good clinical outcomes, as this reinforces the behaviours that contributed to the successful outcome and improves self-satisfaction. The case study presented today highlights the importance and relevance of clinical debriefing in paramedic practice. It is essential that paramedics incorporate experiential learning and clinical debriefing into their line of work to ensure that they are further enhancing their skills and addressing possible medical knowledge gaps to provide optimum patient care. I will ensure that I will always incorporate clinical debriefing into my future practice as a paramedic to ensure I am always learning and reflecting on how to provide more quality and adequate care to my patients.